Thank you very much, Eduarda, for joining us today for this brief discussion on anesthesia for liver transplantation. It's a great pleasure, great honor to have you here. And to start, my first question is, how do you prepare a patient for a liver transplant?
Thank you, André, for having me here. So answering our first question here. Patient preparation for liver transplantation begins with a detailed review of their medical history and current condition. It's essential to understand the underlying disease of this patient, such as cirrhosis from hepatitis, alcoholic disease, NASH or MASH, metabolic, genetic disorders, or just hepatocarcinoma or even MAT from colon cancer. Assess the severity of liver dysfunction, including complications like refractory ascites, hepatic encephalopathy, or renal dysfunction. Evaluate as well the hepatic function, cardiac and pulmonary comorbidities, and of course, relevant tests. All these will allow the anesthesiologist to optimize and anticipate intraop complications. About the access of this patient, so the arterial line is generally established pre-induction for hemodynamic monitoring and blood gas sampling. Radial artery cannulation is preferred, but femoral access may be used in specific cases for more accurate pressure readings during hemodynamic fluctuations. There are some centers that still do dual radial lines to have one as a backup. And for venous access, two central lines are typically placed in the internal jugular vein, one large bore introducer for rapid infusions and vasoactive drugs, and another one, triple lumen, or even a dialysis catheter for other needs. Of course, all of them with ultrasound guidance. Of course, it's standard to reduce complications in these coagulopathic patients. So talking a bit about advanced cardiovascular monitoring, it's tailored to patient risk. Pulmonary artery catheter measure the cardiac output and pulmonary pressures, while TEE offers a real-time assessment or ventricular function, hemodynamic, and hemodynamic stability. Other devices that we have, like minimally invasive monitors, are alternatives, but they are less reliable in scenarios of large fluid shifts or vasoplasia that we see often in liver transplantation. Other monitors that are good to include in our care are neuromonitoring of depth of anesthesia, neuromuscular monitoring, of course. Cerebral oximetry is used in some scenarios to track brain oxygenation during critical phases, such as anhepatic and reperfusion periods. We can also include the defib pads on patients that have higher risk of cardiac complications during the liver transplant. It's always good to have upfront rapid infusers and warming devices because they are critical for managing massive transfusions. About the anesthesia management, so we should focus on balanced general anesthesia, avoiding hepatotoxic agents and adjusting doses for impaired metabolism. Induction typically uses reduced dose of propofol with vasopressor support to prevent severe hypertension. We can use etomidate or ketamine as safer alternatives in stable patients, and rapid sequence induction, we will think more in patients that have significant ascites and encephalopathy. So intraop preparation includes like initial arterial blood gas for analysis for oxygenation, ventilation, lactate levels, and of course, ROTEM is also performed at key surgical stages to guide coagulopathy management.
Perfect. Thank you very much, Eduarda. And you talked about hemodynamic monitoring. And talking about that, what is your opinion about the use of the pulmonary artery catheters as a routine in liver transplantation and the transesophageal echocardiography as an alternative? What do you think about these two monitors?
So when we are preparing a patient for liver transplantation, of course, we are expecting hemodynamic changes, especially in classic cirrhotic patients. They often present a hyperdynamic state, meaning that they will have typically like increased cardiac output, pulmonary artery pressure also increased, while systemic vascular resistance, it will be reduced due to vasodilatation, splenic sequestration. And the severity of these changes in these patients is closely related to the degree of the liver dysfunction. And understanding this will allow us to anticipate complications and adjust our management. So in terms of monitoring, one of the tools, of course, as you said, pulmonary artery catheter. This catheter will be essential in some cases, like, for example, when we have a patient that we are suspecting of pulmonary hypertension, because we'll have like continuous and direct hemodynamic monitoring and check this increase of this pulmonary artery. And of course, in those patients that we have ventricular dysfunction is also, it's a good tool for us to have during the transplant. But because with the pulmonary artery catheter, we get like a real-time data on the pressures, left ventricular preload, cardiac output, and also venous saturation. This is invaluable for detecting issues like, for example, a drop in cardiac output, which could lead to a cardiovascular collapse, especially in those patients that, in those cases that they have right ventricular dysfunction and can arise with a sudden increase in pulmonary vascular resistance. However, of course, it's important to note that PAC is an invasive procedure. It carries other risks like arrhythmia or perforation, and it's also not always necessary. We can't say that it's like a device that we have to always use in liver transplantation, but because we do not have enough literature that can say this to us, it's not a device that we have to use sometimes, in particular in those patients that have underlying conditions. For example, patients that are going to do a transplant just because of the hepatocarcinoma. These patients, most of the times, they are not classic cirrhotic patients. So in these patients, we can assess the need of that. And talking a little bit about more a little bit more about the TEE now. So the TEE allows us to assess the heart in the real time, evaluating things like ventricular function, intravascular volume, and possible hemodynamic complications. It's particularly useful for diagnosing causes of hemodynamic instability, such as hypovolemia, myocardial dysfunction, tamponade, or embolism. It also will help us monitor the volume status of the patient, allowing to make more precise adjustments in our fluid management. That said, TEE that does have some limitations. For example, it's not suitable for all patients. Patients that have advanced esophageal varices, for example, grade 3, and there is a relative contraindication for grade 2, or patients that had recent bleeding or recent bending, these patients, we won't think about placing TEE on them. It also doesn't directly measure pulmonary artery pressure. Instead, it gives an indirect estimate based on tricuspid regurgitation, which is only reliable if the regurgitation is significant. But what is important to remember, the TEE, that sometimes, like here, we have an additional team, a team support with expertise and, of course, the equipment that will do the TEE, while the other anesthesiologist, the other anesthesiologist is taking care of the patient management. So we have to be always mindful of that as well. So ultimately, both PAC and TEE are complementary tools in liver transplant anesthesia. They do not exclude each other. So PAC is, as I said, especially useful for continuous monitoring of critical parameters during unstable periods like reperfusion. And on the other hand, TEE provides a detailed and dynamic view of the heart's function and intravascular volume, making it invaluable for real-time decision-making during surgery. So, as I said, many centers use both tools together, which allows us to take full advantage of their respective strengths. So PAC for continuous, accurate hemodynamic measurements, and TEE for detailed visual assessment. However, there's no universal consensus on the ideal approach. In some centers, one tool may be preferred over the other, depending on the clinical scenario and what tools are available, of course.
Perfect. Just a quick question about the PAC. Do you think that there is any benefit to use a continuous cardiac output PAC as compared to the intermittent one? Do you think there is some evidence of benefit? And what do you recommend regarding these two different types of catheters?
So I know it depends also of the device that you have available. For example, here I know that we just have now the intermittent cardiac output available, but I really think the continuous cardiac output is better because we can make like real-time decision making. We can make this real-time decision, and then also assessing like dynamically what the patient is in the need at the moment, as like we're like sparing some time just to do like the measurement and everything. Sometimes we know how liver transplants are very dynamic, very busy, and stopping and then doing the intermittent cardiac output sometimes it's not a thing that we can do all the time. And if we have like a continuous cardiac output, it's always better, of course.
Perfect. And another question related to bleeding risk and coagulation, which are certainly major concerns in liver transplantation. What are the main strategies for managing bleeding and coagulation in these patients?
So coagulation monitoring liver transplantation is essential for managing intra bleeding. Viscoelastic tests like ROTEM and TAG, they will provide a real-time, detailed information about the clot formation, strength, dissolution, and these are the most reliable tests that we have nowadays to manage the coagulation. Of course, we have the standard coagulation lab tests such as PT, PTT, and INR, platelet count, that we can still use, of course, but they do not provide a complete assessment of hemostasis, and they are not dynamic. So a little bit more about the management of the coagulation, talking a little bit about antifibrinolytics. So the use of antifibrinolytics such as tranexamic acid and aminocaproic acid, they are indicated to reduce hyperfibrinolysis, a common complication that we see in liver transplant. So while the prophylactic use of both lacks consensus, studies suggest that they can reduce the bleeding during the surgery, can reduce the transfusion as well, such as red blood cells of plasma, without increasing the thromboembolic complications. But nowadays, we do not have a study that we can rely on and do it prophylactically. While some centers are super against doing antifibrinolytics in liver transplant, there are other centers that are doing off-label prophylactic tranexamic acid, for example, for patients. But so far, what we have in the literature is that the administration should be adjusted based on the presence of the hyperfibrinolysis detected by the ROTEM, or in case if we have like a diffuse bleeding without other cause. About fibrinogen. Fibrinogen is the most important coagulation factor that we have, and we have to administer it when there is the need, when the exams show us that. We can use cryoprecipitate because of course it contains fibrinogen, and when fibrinogen concentrate is unavailable, for example. And of course, plasma is also a third alternative that we have, but it contains just a limited amount of fibrinogen. About the platelets, we know that platelets play a crucial role in hemostasis, but in liver transplant, we have to keep in mind that we should administer carefully platelets in these patients. So platelets transfusion is often avoided until the hepatic artery anastomosis is complete. The platelet transfusion may be indicated in cases of significant bleeding or impaired platelet function. However, indiscriminate use may be associated with worse post-op outcomes, particularly in patients with complex coagulopathies. The fresh frozen plasma contains, talking a little bit more about this, contains numerous essential coagulation factors and also anticoagulant factors. It's used to correct coagulopathy during the dissection phase when significant bleeding occurs. And its transfusion should be guided by clinical bleeding and TAG or ROTEM to avoid overtransfusion and complications like TRALI or even thrombosis. The proton ring complex concentrate, the four-factor PCC, may be administered instead or also in addition to FFP. And it contains coagulation factors as well as anticoagulant factors and a small amount of heparin to reduce the risk of excessive thrombin generation. The PCC has the advantage of being rapidly administered in small volumes, reducing the risk of volume overload in these patients and transfusion reactions as well. However, it has the disadvantage of containing smaller amounts of other coagulation factors that FFP provides, which may limit its efficacy in certain situations. And the use of PCC is still a controversy in the literature because there is a lack of studies related to it regarding the allegedly higher risk of thrombosis. So there are some still centers that are careful using it. Packed red blood cells, of course, are used to correct anemia in patients that have a hemoglobin levels below 7, 8. We do not have a standard number to transfuse these patients, and their transfusion should be individualized based on clinical assessment and, of course, monitoring results. And the last one is the albumin. Albumin is a blood product used for volume replacement, particularly in patients with low albumin levels. However, the use of albumin in liver transplant is debated, and its impact on bleeding is not well established in the literature. Its administration is generally avoided during the early stages of the transplant when bleeding control and minimizing fluid are prioritized. While it has theoretical benefits, its use should be weighed against the patient's clinical condition and the risk of increasing bleeding. So this is another blood product that still has controversy in the literature and has a different approach of using in among liver transplant centers. So in the end, it's a delicate balance between maintaining adequate coagulation and not overcorrecting to the point of predisposing the patient to thrombosis. Excessive transfusions should be avoided, and fluid resuscitation should be ensured with balanced crystalloids. The replacement, we should guide dynamically in these patients to prevent dilution of coagulation factors and also potential of exacerbation of the bleeding.
Perfect, Eduardo. And we have, of course, critical phases during the liver transplant. Each of the three phases, the pre-hepatic, the hepatic, and the hepatic phase, are related to some goals that you have. For example, in the dissection phase, we are always concerned about bleeding. But there is a special moment of the procedure, that is the reperfusion phase, that we should be prepared. And my final question is related to that specific phase. How do you prepare the patient for the reperfusion, the venous reperfusion? And when you have, for example, after reperfusion, you have vasoplegic syndrome that's sometimes we observe in liver transplant. How do you recommend the management? How do you manage these patients when more severe case of vasoplegic syndrome is established?
Okay, thank you for the question, André. So the preparation for reperfusion, first thing. So blood gases and electrolytes should be checked with aggressive treatment for hyperkalemia. For example, potassium levels should ideally be under 4 to 4.5 before reperfusion to minimize the risk of severe hyperkalemia and also cardiac arrest, of course. Magnesium sulfate, it's routinely administered during the anhepatic phase for membrane stabilizing and antiarrhythmic effects. So 25 milligrams per kilo before reperfusion has been shown to lower post-reperfusion lactate levels, for example. Also, calcium levels should be normalized, and bicarb should be given to correct the acidemia. All issues have to be resolved before reperfusion, so we do not have, we should not wait for the reperfusion syndrome to treat those things. We should think in advance and treat them before it becomes a real complication. So, because as you said, the reperfusion phase is the most critical phase of the transplant. And of course, proper use of vasopressors like noradrenaline, vasopressin, adrenaline in some cases also is critical during this phase. A little about the vasoplegic syndrome. So it will result as a distributive shock that induced by the graft reperfusion. The initial phase, like the initial treatment, it will involve the administration of standard vasopressors such as norepi or vasopressin, depending on the center that you are. For example, here, they prefer vasopressin. In the refractory phase, in cases where hypertension persists despite initial vasopressor therapy, we can use adrenaline, can be considered, of course, for managing critical hypertension. And additionally, methylene blue can be indicated with an initial dose, like a loading dose of 1.5 milligram per kilo. And if we have a positive clinical response, we should do a maintaining dose of 1 to 2 milligrams per kilo. In extreme cases, like in severe refractory cases, more aggressive interventions, such for example, we should place an ECMO on these patients, but it's like extreme cases. And indicators, of course, of the graft recovery when we did all these measurements for the patient to be well recovered, so the graft can be recovered. We can see with the normalization of the calcium levels, increase of the blood glucose, improvement in the acid-base balance, lowering lactate, and increase of the blood temperature, rising the CO2, recovery, hypotension. I mean, we have a lot of things that we can see in the patients, in the tests, and also, of course, in our devices that we can see that is improving, that are improving in the patient, that our measurements worked well for this patient.
Perfect, Eduarda. We are almost ending our discussion. Do you have any take-home messages or final message to give to our audience?
So maybe I'll wrap up about everything that I talked today with you. So pre-op evaluation, always remind comprehensive patient assessment is critical. About the venous access, should include 2 central venous catheters with ultrasound guidance to avoid complications. About the arterial access, typically before the anesthesia induction. Intra-op monitoring, advanced cardiovascular monitoring, TEE or PAC, they are essential for patients with complex hemodynamics. PAC will provide continuous monitoring of hemodynamics during unstable phases like reperfusion. TEE will provide a dynamic real-time heart and volume assessment. About the coagulation and bleeding management, viscoelastic tests are essential for real-time monitoring of the coagulation, offering more comprehensive than our standard lab tests. They will help guide transfusion decisions and reduce blood product overuse. Antifibrinolytics, they will reduce hyperfibrinolysis, but we should be careful about them. And nowadays we should use the ROTEM to guide the use of antifibrinolytics. Fibrinogen, platelets, transfusion, FFP, and PCC, they are used based on the hemodynamic needs of the patient, guided by the lab results and clinical status, of course. And about the reperfusion phase and vasoplegia, the reperfusion preparation involves correcting potassium, magnesium, calcium levels, addressing an acid-base imbalances before the graft reperfusion. The post-reperfusion syndrome, it will be managed with an appropriate vasopressor. And in refractory cases, we can use adrenaline or methylene blue. Reperfusion and vasoplegia management should be closely monitored, and the anesthesiologist should act in advance, as I said, with early intervention strategies to prevent severe hemodynamic instability. And this comprehensive approach ensures optimized patient outcomes, reducing risks associated with complex liver transplant surgeries. I think that's it.
Perfect. Thank you so much, Eduarda, for joining us today. It was really a great honor to have you here and have this amazing discussion with you. Thanks so much once again.
Thank you very much, André.